Good afternoon, Europe. Isn't it amazing that we are sharing this day together, even if we are in different parts all over? And that's something I think we all realize today with the COVID and with the digitalization and all the things that is happening, that the world is getting closer and we can have a lot of good things coming out from that. Some of the house rules for this seminar: you can use the chat function. I will also have some polls that I will bring up before and each speaker. So feel free to use that and answer them. It will be very quick. We will do that. I was thinking a little bit about the theme of this day that Scanbalt Forum is focusing on, towards a common European health data space. I, in a way, feel very strongly for that statement. And when you start to think about it, you realize that something that is common is something that all knows about and have agreed on and respect. So those are the three things I think we should carry with us. We need to know about this. So thanks to Scanbalt, we are bringing it up to everyone to hear about it, and also that we need now together agree on what we will do, and we will do that with respect. In this session, we will bring 7 best practice examples from the whole of Europe on how we can use digital solution for the next generation of health research. And with that, I think it's important to understand when life moves on fast, we need to take good care about the research to really understand what is happening. And the research will also help us to move forward. And when it comes to healthcare, we all have talked, as we have heard, about individual healthcare here today. And we see with COVID-19, for example, how different it seems to be to have that disease. Somebody really getting sick of it and someone just has a normal little flu and so on. So I used to say to know that you are special, we need to know so much more about everybody else. So that's something that is in the way that Janos said, sharing is caring. So I think that what the researcher will help us with is to prepare to share. Because it's not easy just to share, as we heard on the previous session. So with that, I would like to invite Sonja Aits from Lund University to talk a little bit about how we can use big data to extract knowledge with some examples from just COVID-19. And you can also show the first poll for us now when we start her video. Thank you.
Hello, my name is Sonja, and I will talk about using big data to tackle COVID-19, both the opportunities and also the roadblocks that we face. And everything I say is, of course, also true for other diseases that we want to tackle with big data analysis. So the good news is that we have an abundance of data. We have by now the patient journals from millions of patients. We also have hundreds of thousands of articles written about COVID-19, even though it is such a new disease. And we have an abundance of bioinformatics data in various databases. We have, in fact, in bioinformatics, so many databases that we need databases of the databases. And all of these information sources potentially have nuggets of knowledge that can help us understand both the virus, but also the host reaction, and potentially even help us find new treatments. The bad news is that all of this information is not easily accessible. It is completely scattered through thousands of institutions and thousands of different information sources. And that's, of course, a major roadblock to gaining insight. We and others have tried to tackle this by setting up data portals which collect the most important sources of data and also resources such as tools that can be used to analyze this type of data. So there is a European data portal initiated by the European Commission, I believe. And in Sweden, we have also set up a matching sister site, which is the COVID-19 data portal Sweden. And here you can find all kinds of biomedical data related to COVID-19, for example, host and virus sequences, different expression profiles, structural data, drug screening results, and so on and so on. You can also find collections of literature. And on the Swedish side, we've also added other data types. And we also have tools such as a list of databases that are relevant. We have lists of infrastructures and consulting services. We also have opportunities for researchers to share their software and, for example, AI models that they have created. And we also link to various networks and discussion groups and to different types of training opportunities. So this is all good. The problem is that much of the data, even though we have it now in somewhat one place, or rather the metadata for it, it's actually completely unstructured data. So this means that much of it is actually in the form of text, free-flowing text, and that is a nightmare to analyze. So we have, for example, scientific literature that is written. We have electronic health records with lots of free texts. We even have social media posts, news reports that may have relevant information for pandemic surveillance, for example. And we have a lot of information in databases, but even those often have free text fields. In this case, artificial intelligence can be a tool to find and connect these pieces of information, and specifically artificial intelligence-based text mining. And you can look, for example, for specific types of keywords and also relationships between different entities. And from that, you can potentially gain insights such as a list of drugs that you can test in a drug screen or other types of information. AI systems can actually also be used to actively watch out for disease outbreaks. So pandemic surveillance today is often done by artificial intelligence systems which crawl through news articles, social media posts, government reports, and other types of information that have potential information about disease outbreaks. And it was one or several AI startups that actually spotted this potential outbreak and alerted their customers very early before the official information came out. So how can we facilitate AI-based analysis of big data in medicine? And this is not just for COVID-19 now, of course. In general, we need to share data, we need to share the code, and we also have to share the trained models. We really need to standardize. This is both for metadata information as to the also for the actual data formats. We have over 100 of different microscopy imaging formats, for example. We also have lots of different bioinformatics identifiers, and they are not consistently used. And of course, we have huge variations in the language, how people write. They use synonyms and different types of expression. We need to have centralized metadata repositories. I don't think it is feasible to actually centralize the whole data, but we need to have a place where you can look where the data is. We also need to have accessible long-term data storage. It can't be up to the individual researchers to store their data, and then when they leave academia, potentially all the data is lost. We also need to have very detailed documentation, everything from experimental details to data processing details, even licensing information, so that we can do a systematic quality control of the data. We also would really benefit from having anonymous data, because then we can trial out small new project ideas without going through the whole ethics review process. And this could really help us iterate much faster if the data was truly anonymous. And we also, I think, need to have a discourse about the ethical issues that are related to AI and big data, so that we're kind of all on the same page of what should be done and what shouldn't be done, and that we are sure that everyone complies with the values that we share. This is, of course, always important to collaborate. So we, as many others do, and in the big data field, it's absolutely essential because you often need to pool data and resources across borders. And yeah, I want to thank everyone who's working with us and who's sharing data and is keeping the open science movement alive. Thank you.
Thank you, Sonja. Very interesting. We move on in the program, and I would like to introduce to you Professor Carsten Ullrich from Centogene in Germany, and he will talk about preventive high-throughput testing SARS-CoV-2. So please, Ullrich, and you can also show the poll.
Hello, welcome to this talk in this session, Digital Solutions for European Health Research. My name is Carsten Ullrich, and I'll talk a bit about how we at Centogene reacted to the crisis that has led to us not being physically present there, but having to virtually attend this conference. So how we transformed as a company and what we did in order to, well, try to cope with that situation. What we originally are doing and what we are still doing is rare diseases. So we work in the field of providing, on the one hand, diagnostics for rare diseases. So physicians can send us biomaterial blood samples of their patients, which we then sequence, where we get the genetic data, the proteomic data, metabolomic data, in order to come up with a diagnosis to see what rare diseases the person is potentially suffering from. That's one big thing we do, diagnostics. The other is supporting pharmaceutical companies in the end, helping people who suffer from rare diseases by finding new biomarkers, by finding new drugs, by understanding better what happens in the cells if someone suffers from a rare disease. And in the end, what we are a data-driven company. So the value of what we do, it's not in the sequences. I mean, everybody can buy a sequencer. It's an expensive piece of equipment, but everybody can buy it today and sequence a genome, but really interpreting it, getting the most out of it, identifying those parts which are relevant for the diagnosis, improving the diagnostic processes, and so on and so forth. This is what you require data for. And at Centogene, over the years, we have collected data from more than 450,000 patients, in which is in the area of rare diseases really unique. And we use that data to understand better what's happening in these patients and then to help pharmaceutical companies to come up with new treatments. Well, this is what we do, what we have done, but then, as we all know, something happened in the world. It started innocently with a few tweets by the World Health Organization with a cluster of pneumonia cases. And then today we are here in this situation with 25 million cases of COVID and massive effects on the economy. So of course, we ask ourselves, what can we do as Centogene? And what we do, where we have the experience, is in testing. Genetic testing for rare diseases. And it's not so difficult, if we come from that field, to apply that to this new field of COVID testing. And we certainly believe that testing, it's highly, highly important, and it's essential to identify those persons who suffer from a rare, not rare disease, but in this case from COVID, who does not suffer from it, whom do we have to quarantine, and who can just pursue his life a little bit as normal. So testing, large-scale testing, that's really essential for the individual to know what state I am, but also on a larger scale to evaluate trends and then to come up with the correct health measures. Over the last month, what we did is we built up our own solution for COVID testing, starting with the collection kit, with a swab that you put in your mouth to collect the salvia, which we analyze to find the remains of the virus. At some point in May maybe there were no sample collection kits available anymore in the market, just like we had with toilet paper and masks. It's the same for other materials. So we built up our own supply chains. We are building now our own sample collection kit, the CentoSwab. And this is like the basis which we then, where we collect the data in our registration portal, where we use our instruments to do the high throughput testing. And what you see here on the left is the Cento swab, and on the right, what you see is the Cento truck, a mobile lab that can drive anywhere to do testing on site. And we knew from the very beginning we had to go digital. In order to avoid the problems that we saw in Bavaria, where 40,000 people were waiting for the test results because they didn't know what probes were for what people and who to contact them, well, you have to go digital. And in our portal that we built for the corona testing, you register with a valid email address, you give your personal details, and it's there. And the material that you use for swapping, it's connected to your ID. So starting from the collecting of the testing material to the medical reports that you get, everything is digital and highly protected according to highest data security standards. We are talking about very sensitive information here. IT AI plays like a supporting role because the processes of doing the testing and looking for the remains of the virus, this is quite well established in the bioinformatics pipeline. AI is mainly used for understanding where the tube wrecks are, whom are they associated to. So it plays a supportive role, but it's necessary for upscaling. What else do? We publish our methods. So at this point, we really believe in open science. We have a paper that describes exactly the tests that we are doing, what we have set up in order to do this high throughput testing. So it's available as a publication. We have a little site on our website where we curate other relevant scientific articles. So if you go there, you find other important information about COVID coming from relevant sources. And what we also do, we publish our statistics, the things that we learn at Frankfurt Airport, where one of our testing centers is. Well, you can go there and see how many patients were tested yesterday and how many results did we get. So we show it by city in Germany, but also by country. And of course, this information is highly relevant in order to decide which countries are risk countries. So very brief, what we are doing at Centogene in order to cope with Corona and how we used our digital infrastructure, data-driven infrastructure to quickly build up this new environment for us. Thank you so much for your attention. Looking forward to your questions later.
Thank you for a very good understanding of what you achieved. We move on our program, so I welcome Professor Alfonso Valencia from the Barcelona Supercomputing Center in Spain, and he will talk with us about the COVID-19 medical data and the medicine of the future. So please use the poll and also start the presentation from Barcelona.
Good afternoon. Thanks for the invitation. My name is Alfonso Valencia. I'm the director of the Life Science Department of the Barcelona Supercomputing Center. First, let me introduce you our big supercomputer. This is Mare Nostrum, one of the largest computers in Europe, and the reason of being of our center that is on top of a resource for supercomputing, a large institute dedicated to the use of high-performance computing in a number of areas. In my case, the applications to life science. What I'm going to do in the next few minutes is to tell you some of the things that we are doing in the context of the COVID-19 epidemic, dedicating many of our resources to the fight against the disease as many other institutes in Europe. Let me share my screen to show you some of the things that we are doing obviously without trying to be exhaustive at all. We are deeply involved in a number of European projects. To show you one of them, a large collaborative effort, Exascale for COVID, collaboration between research institutes, companies, and 3 of the large research computational facilities in Europe, including the Barcelona Supercomputing Center. What we are doing in this case is trying to understand the variability of the virus, studying the genomes of the virus, trying to understand what is vulnerable and how it is interacting with the human proteins. Using this knowledge at the genomic level, transported to the molecular level, trying to understand how to target the human or the viral proteins with drugs, repurposing existing drugs, or collaborating in a number of projects, including a local collaboration in Barcelona with a pharmaceutical company in developing vaccines in the fight for vaccines that is going worldwide. So this is the use of computational simulations at the molecular level. From this stream, we can cover many of the other areas. I showed you the other stream, that is the simulations at the level of epidemiology. In this case, what we are doing is combining data on mobility maps based on cell phones, movement of people with cell phones, with disease data, number of cases, incidence of cases in different locations, in a way that we can trace how the movements of people from one location to the other are the possible origins of outbreaks, and to the extent that this is possible, to predict new outbreaks in a complex situation of a lot of movements and new cases. The way we do that is very much based on the capacity to do computing and using a theory coming from network theory to understand the connection between different places in terms of movements and diseases. All this, from molecular to epidemiology, is based on the use of data. We need data. We need accessible, high-quality data. This is one of the efforts we are participating in collaboration with the European Molecular Biology Laboratory, the outstation in the European Bioinformatics Institute, with the infrastructure for bioinformatics in Europe, Elixir, an European infrastructure, and with EOS-IVE, the European Open Science cloud dedicated to life science. In this case, the effort is to put together a collection of genomes, human and viral genomes, together with the other databases in what is called the European COVID-19 Research Data Sharing Platform. There are already thousands of humans and viral genomes collected in the database in a way that we can understand the connection between the susceptibility in humans and the variability, potential variability in the virus. This is important in the context of Europe. This is a federated effort. Each one of the countries is developing their own portal to host the data and to be able to share it with the other data. I showed you here the example of the general portal, the European portal, and also the local instance, in the case, the first one that was up and running, the Swedish COVID-19 data portal. So the challenge is to put together this genomic information, but very important is to be able to combine this with the medical information. And this is really the difficult bit, to put together the medical information that now is contained in databases, in hospitals and institutions, and is difficult to access. Is this useful? I can show you many examples. I showed you one that we are publishing these days, working with a chain of hospitals in Madrid. We can use this information to predict the disease outcome over the days, from the entrance to the hospital to what is going to be, based on the machine learning methods, the outcome of this case in a way that there can be preventive measurement for the cases with a bad outcome. And of course, this is now extended to other big hospitals, 12th of October clinic in Barcelona, 2 hospitals in Madrid and Barcelona in Spain. This is not enough. We need more information. Another branch of artificial intelligence, the natural language processing, used for extracting information about COVID-19 variables from electronic health records. A full field to be exploited given the amount of information contained in the medical record. So I finished saying that data is essential, has to be accessible, interoperable, and trustable. We have shown in proof of concept that the importance of having this data accessible. We have shown in these few minutes the importance of the infrastructures, Elixir, the databases, the computational capacity, Barcelona Supercomputing Center, Euro, HPC. And also I told you about the potential of putting together data in the case for COVID-19 that is technically feasible and ongoing, but the difficulty of putting together the medical data. Finally, COVID-19 is a catastrophe for Spain, it's a catastrophe for many other countries too, but we have to be positive and to see this as a source of opportunity, because what we are doing these days will shape the future of the medicine in the years to come. Thank you very much.
Thank you, Alfonso. I like the remark of we are shaping the future for medicine, because it might be that we are addressing a little bit of a paradigm shift here. Next up will be Professor Adriana Maggi from Milano Innovation District, MIND, and she will talk about the Lombardy Region COVID-19 Biobank Network. So please start her pre-recording, and you can also bring up the poll.
Good afternoon. I'm Professor Adriana Maggi, and I'm Vice Rector at the University of Milan. The project I would like to talk about today was born at the Milano Innovation District, MIND. This district in the region Lombardia is a strong public-private partnership that comes from the Expo 2015 meeting. And these partnerships sees several enterprises that are private, like Arexpo, that which mission is to transform the area of Expo 2015 into a district for science, technology, and innovation. Lend-Lease, that is the developer of the whole area. The hospital Galeazzi, that has more than 500 beds and more than 25,000 patients, together with the public companies like Human Technopole, that is a new national life science research center devoted to translational research. Fondazione Triulza, that has a network with 68 civil society organizations, and the University of Milan, that is the biggest university in Milan, with more than 60,000 students. 18,000 of them are devoted to science, and all of them will be transferred to the MIND Science very soon. And we work together with all the other companies that are present there. As you know very well, in the last few months, Milano and the entire Lombardy were hit by the pandemic of COVID-19. 95,000 people were infected, and now we were able to fight this infection and this pandemic. And what is left is an asset of biological samples that are fundamental for our research and to enable us to find new remedies, new ways to prevent and treat this infection. However, all of these samples are not in a single biobank, but are fragmented in the different biobanks in the territory. So the project that we wanted to have was to facilitate the consultation of these biobanks and analyze all of these samples, and enabling the researcher in an easy way to classify them, to consult all the medical records regarding these samples. And to do that, we have to generate a pilot project that enables the collaboration among all these hospitals. And this is a totally new way to collaborate that we have to come up with. So to do that, we generated an infrastructure, and this infrastructure is a user-friendly digital system that is like a Rosetta Stone that will enable the different banks to speak a similar language or the same language. And together with that, we will have a core facility that will be responsible for helping all the other hospitals, smaller hospitals not having biobanks by themselves, to enter their samples in the bigger biobanks. And this core facility will be also responsible for the experimental design and management of population studies and big data management. Part of the people in the core facility will also start a pilot project to generate all the methodologies necessary to run a RNA biobank. The future activities are, first of all, a generation of a PhD program that will be run by the University of Milan, that is necessary as we have a strong need, and we have realized by talking with the private companies that we have a strong need of health managers with a very comprehensive background that is multidisciplinary and intersectoral, and this is very important in the to operate in the medical field. Then the hope is to extend this pilot project to all the other biobanks and to create, together with the region Lombardia, new methodologies to apply to future banks in order to have an harmonized, defragmented system. What is the strength of our project? I think that the first strength was unexpected and is this beautiful integration that we have between public and private health sector. And so far, this was very useful also because it helped us to talk with the region Lombardia. The project has a long-term commitment, has very strong scientific basis, and we are sure that it will attract, and is already attracting, a lot of other companies interested in collaborating with us. Those companies are interested in drug repurposing using our banks, but I'm sure that we will work together also with the universities in order to find also novel drug targets. The beauty of our biobanks is that we have very full, very complete medical records together with our samples in the biobanks, and this will certainly facilitate and speed up pharmacological research in all the data that we have stored. So with our project, we believe that we will collaborate to the European economy, the regional economy, and certainly to the health of the citizens, both in Lombardy and in the entire Europe. As you can see, we started out in few, several others are now joining us. There are several big companies that are interested in our project, and we are starting to talk with them. So the constellation of the mind ecosystem is rapidly growing, and I think that this project is just a beginning of several other projects that will stem with, by this very strong partnership that mind represents. I thank you for your attention.
Thank you very much, Adriana. I really liked the way you said you have started to, you have found the Rosetta Stone. I think it's important that we see how we can use all our knowledge together. For the next speaker, I would like to introduce Dr. Klaus Donza from Johanneum Research Institute for Biomedicine and Health Science in Austria. He will talk about BARS, the digital warehouse for COVID-19 stratification. So please start his pre-recording, and you could also bring up the poll.
Hello, everybody. Today, I'm going to talk about our benchmarking and reporting service BARS in the context of a common transnational data space and, of course, in the context of the current COVID pandemic. The web-based service BARS was developed and is hosted by Johanneum Research, which is a non-profit research organization in Austria. Johanneum Research has around 500 employees and is organized in 7 research institutes. Health, the Institute for Biomedicine and Health Sciences, is dedicated to develop solutions to support medical decision-making and adequate patient care. We are located in Graz, directly on the campus of the local university hospital, which is also one of our partners for projects and clinical trials. In several of our projects, we encounter that healthcare professionals and healthcare decision makers often face the problem of unknown potential for risks. E.g., what expects me when I have to perform surgery in this particular patient, or how likely will this patient develop complications? Required information for risk stratification, however, is fragmented across multiple data sources and is often not available in a standardized way. This information is necessary for efficient, evidence-based decision-making and resource planning in healthcare. A large meta-analysis published in the Cochrane Library showed that older people living with frailty benefit significantly from targeted interventions, which improve health and also independence. However, access to specialized healthcare facilities must be regulated due to limited healthcare resources. Therefore, patients have to be selected according to certain criteria. On the individual level, age alone has little prognostic use. This was also shown in a guideline recently developed for a hypothetical flu pandemic. As a tool for selecting older patients benefiting from targeted interventions, frailty screening is internationally recognized. There are several different scores available, most notably FREED, EFI, CFS. Frailty is also relevant for risk stratification in the current COVID pandemic. As COVID disease outcomes were better predicted by frailty than either age or comorbidity. This was published recently in The Lancet, and this fact is very important to consider for the systematic I'm going to present in the next few slides. To assist and facilitate domain-specific quality assurance in healthcare based on primary data, UNM Research developed the web-based benchmarking and reporting service BARS. This service enables standardized collection of real-world data for audit and feedback purposes and to perform detailed individual online analysis and reporting. The system is live since 2008 and is and was used in disease management programs in Austria and also in Germany. Currently, around 40% of all acute geriatrics and remobilization facilities in Austria participate in an open audit and feedback quality assurance program using BARS. BARS establishes a common data space. It enables detailed characterization of patient populations. It digitizes documentation, standardizes care processes and clinical processes, and overall improves quality assurance. In 2018, we started with the modernization of the audit and feedback service and linked our benchmarking system to innovative e-health tools. Our aim is to enable prospective and retrospective risk stratification in the care of the elderly. Our guidance system can be used for frailty risk screening in emergency departments or surgery departments, and our therapy monitoring system offers process and decision support in specialized care facilities for the elderly to capture high quality and structured real-world data. The collected real-world data enables, on the one hand, risk stratification for healthcare professionals on an individual patient level through the BARS guidance system. On the other hand, regional risk stratification for a severe disease progression of, e.g., COVID-19 or flu pandemic for healthcare decision makers. In Austria, we can characterize the risk potential based on frailty, comorbidities, demographics, etc., by using structured real-world data from many institutions or regions and applying a series of data models. This enables informed, detailed resource planning for healthcare decision makers. To sum up, unknown risk potential complicates resource planning for healthcare decision makers. Frail patients are discharged from hospitals less quickly and are more likely to die from COVID-19. BARS enables automated and standardized collection of real-world data from risk groups as well as prospective and retrospective identification of patients at risk. Real-world data on risk potential can be used for regional resource planning and for defining risk mitigation measures, such as where to vaccinate first. Thank you very much.
Thank you, Klaus. It's impressive to see that we have the so good tools so fast to be used. We continue in our program now, and we go to Dr. Karolina Zauczuk from the Center for Computational Personalized Medicine in Poland. And she will talk about computational medicine challenges in the time of pandemics. Yep. Great. So please start her pre-recording, and you could bring up the poll.
Good afternoon, ladies and gentlemen. First of all, thank you very much for inviting me to present at Scanbalt Digital Forum. Today, I would like to talk about the challenges we face in 21st century, followed by the capabilities we have gained over the last 2 decades, and how can we use them in real life. Last but not least, I would like to mention a few challenges and their consequences for computational medicine. And to end on a positive note, I would like to invite you to collaborate with us. So what are the challenges of the 21st century? Over the past 2 decades, there's been tremendous progress in terms of medical and computation technologies. These advancements open a completely new gateway for the support of the medical personnel and patients' treatment in general. However, as you can see on the slide, the complexity of medical challenges we are still facing are huge. We live in the aging society with vast number of comorbidities, but the capacity of specialistic care is still very limited. Moreover, we do employ population-specific treatments, which may lead to imprecise diagnostics and finally suboptimal patient care, which gives us a fragmented care. So what could we do about that? We could employ in silico medicine methods to limit the complexity of the problems we have. And of course, supercomputers can work all night long, 24/7, so we have unlimited capacity. This week, we can create subject-specific precise diagnostics and help doctors to prepare guided treatment and provide integrated care. So what are the capabilities we have in hand right now? Here I could tell you a few words about what we do have in Sano. As you can see on the screen, there are a number of things we can do. However, of course, in the research society, there are more than that shown on the slide. So what Sano can do and how Sano can contribute. So as you can see, we have a number of different research units. Personal Health research unit is aiming at personalizing medical services by adjusting diagnostics and therapeutic strategies to the needs of specific patients. Modeling and simulation team develops models and mechanisms to simulate processes relevant to the therapy in healthcare. And as the name says, extreme scale data and computing can deal with infrastructure and huge data sets. Health informatics is a multidisciplinary team working on the interface of computer science, sociology, related sciences, focused on patient data management. Clinical data team is obtaining data, managing them, and sharing them for the purpose of research. And computer vision, the last team, is dealing with not only with image processing, but also with this visualization of all the other research we have in Sano. So what can we do with them? As Sano, we decided to work in 4 different areas. First of all, we focus on science and work on strong advancements of models, algorithms, and technologies that would lead to the decision support systems for clinicians, which we hope to translate and make possible to be implemented in the clinical world, in the real world. And of course, to make it all possible, the education is needed and PhD programs are needed to first create the solutions and then to train the clinicians to be able to use them. And of course, apart from all that, we would like to support businesses. So what are the challenges of computational medicine? I would like to present them on the example of one of the projects we do in Sano. The problem we're trying to solve is to find the correlation related to the progression of COVID-19 and create a toolkit for time series analysis that would help clinicians to make better decisions on the fire front. So what did we start with? We started with the blood test results from patients suffering from COVID-19. These samples came from Brazilian and Polish hospitals, and there were time course measurements for all the patients we had. What did we do? We created a solution using machine learning that would help us predict and see if we are able to predict the progression of the disease. That would further on help clinicians in clinics. So why am I talking about the challenges? Well, the main obstacle here is that the access to the data is very difficult. We lack a clear regulation on data sharing, especially in Poland, probably in all other countries as well. We do not know where the registries for giving data and giving indications, which is especially important for the diseases where there are not so many patients, like rare diseases, for example. There are no very well functioning data alliances, which makes acquiring large data sets very difficult. And of course, then there comes the data quality problem and ununiform data sets, different data collection schemes, and so on. And at the end of the day, we also have no clear path how to proceed with IP protection. So what are the consequences of all that? Of course, we have difficulties with tracking appropriate data sets and given data types for the projects, which limits the collaboration opportunities between countries, and the lack of good, clear legislation how to use the data for international projects. And of course, owing the data we have, these are the types of algorithms we can create. So if we put the rubbish in, we'll obviously take the rubbish out. And that can result oftentimes in poor quality of solutions we create, or not enough robust solutions we can create. So not to end on the very negative side, because we hope to come up with a common solution to this problem, I would like to invite you to collaborate with us. It's very simple. It's enough to contact me via email. We'll see if there's any common interests, scientific or research interests, and then we'll make sure that we meet all legal and scientific requirements, and finally kick off the meeting. So here's my contact data. Please feel free to contact me after the conference, and hopefully we'll create something amazing. Thank you very much.
Thank you very much, Carolina. I liked your invitation to collaboration. I have used to say sometimes, if we prepare to share and we start sharing, we often have the phenomenon of I'm sharing, who cares? So that's sometimes difficult when we would like to work with others. So I think it's a good initiative here with the Scanbalt Forum to actually make the possibilities that we support each other with the sharing. It was also good input for the joint declaration paper that we are working on. Last presenter in this session will be Professor Sebastian Merkel from the Bochum University in Germany. So please start his pre-recording, and also you can bring up the poll.
So good afternoon, everyone. Thanks for giving me the opportunity to present our project Co-op for Health.NRW here at the Scanbalt Forum 2020. My name is Sebastian Merkel. I hold the Junior Professorship for Healthcare and eHealth at the Faculty of Social Sciences at the Lund University in Bochum. Now, Co-op for Health, as you can see by the subtitle, a health data cooperative is essentially what the title suggests. So what we're trying to do here is we're trying to set up a data cooperative. And when I say we, then of course I'm not on my own. We are a whole consortium with different partners. We have the Ruhr University with the Faculty of Medicine. We have the University of Maastricht, who have a very long background in data cooperatives and cooperatives, and we have, of course, the leader of the project, a private agency within the fields of health and social care called Contact, which is also located in Bochum. Now, the whole project is funded by the European Union as well as the state of North Rhine-Westphalia, and that's why it actually is named Co-op for Health.NRW. Now, just to give you a very basic idea of where we're coming from and why we are trying to do what we're trying to do. So I think we all are aware that nowadays we produce vast amounts of data in general, but specifically as we focus on the healthcare sector within the field of healthcare. And not only as part of clinical data or medical data as part of the treatment diagnosis processes, but also we as individuals using our smart devices to track some health parameters, etc. So now this amount of data leads to a couple of questions that need to be addressed and asked. This includes, of course, questions considering data ethics, data security, but it also contains questions of how can we make the best benefits out of this data. So how can we use this data to actually have the most positive effects for the patient, but also for the healthcare system itself. And this leads to the questions, of course, how can we manage this data, how we can make it accessible, and how can we share this data between the different stakeholders on a national level, but given the fact that this is an international conference, of course, also on the international, on the European level in our case. Now, these questions, they have been discussed by a couple of stakeholders during the last couple of years, among them the WHO, OECD, but also the European Union, of course, and the member states of the European Union. And without going into detail here, I've just highlighted a couple of common principles that these new approaches of data governance have in common. So data processes, data sharing here should be transparent, it should be secure, of course, and one of the most important aspects is that it puts the citizens at the center. So the citizens have the right to access and share their data. They decide ultimately with whom do I want to share my data. And this will lead hopefully or ultimately to the empowerment of citizens or patients in this process. And of course, I've just said that one of the main challenges is to have all these different stakeholders who all have different access to different kind of data to work together in a sense that we can actually make all of this work. So this is the background where we're coming from, what we want to achieve within our project Co-op for Health. Now, to give you a bit more specific idea, we are trying, so the ultimate goal is we're trying to, we will found a cooperative and we will to build up this cooperative. Now, again, I won't go into detail here about the what a cooperative is. I've just highlighted here a short definition for you, but we can find cooperative in nearly all different kind of sectors, among also in healthcare. Now, the basic idea of cooperatives is actually to have a democratic, transparent, independent decision process with equal rights and in most cases non-profit. So a cooperative, or the most important part of cooperatives, are of course the members of the cooperative, in our case the citizens or the patients, and they're at the very center, so they decide what the cooperative will do. They decide to which stakeholders we will approach to have this data government, or to realize this data government approach. And just to give you an idea about what I'm talking about here is I've just highlighted a couple of stakeholders that we will approach within our project and that we want to address as becoming part or becoming engaged in the cooperative, to cooperate with it, so that data can be exchanged between all these different kind of stakeholders, but with the cooperative and the members of the cooperative at the very center. Now, of course, this is a huge task, but we won't focus on the whole healthcare sector, of course. So we'll start at a local level with a couple of use cases that we are currently working on, and we want to address as many stakeholders as possible to engage with us into this co-production process to design all those features that the cooperative will deliver. And speaking of this, at the very center of our ideas of the cooperative will be a digital platform that will enable the users, the members, to store their data, to manage their data, and of course to decide with whom they want to share the data. But this will not only be the case for the members of the cooperative. This will also be a place where all these stakeholders have just realized can actually engage in and can also say that we want to provide our data. We want to use this digital platform to actually engage, get in touch with all with the cooperative as a whole, but also with all the other stakeholders I've just mentioned. Now, this slide just shows all the goals that we're trying to address here. And as I just said, that we have just recently started, we will have a lot of work ahead of us. But the good thing is that we'll open for everyone who wants to get involved, who is interested about our project, the idea of our project. So if you want to contact us, feel free to drop us a mail. Here are my contact details, as well as the contact details of Julian Ben, who has been also involved in this project from the very beginning. Thank you very much. Looking forward to getting in touch with you.
Thank you, Sebastian. Very interesting findings and things you have done. Now we have a couple of minutes left on this session, and we will use it for a panel discussion. So if you please all turn on your cameras so I can see you in real. Perfect. Thank you so much for a great insight. And I mean, you always sitting in conferences are so impressed over so much we know and how little you know by yourself. So it has been great to share this with you. We will go through some of questions we have received and prepared, and I will address who will answer first and next and so on. So I will be in charge of that. Great to be that for once in my life also. But I was thinking about if we start with Sebastian, that was on latest here. When you've been listening to all these things here and you've been joining this day here, do you think we will be better prepared for the next pandemic? What should we think about? What should we need to improve to do that? And when Sebastian is answering, I would actually like you all to give a small remark on what your thoughts is about that. So please, Sebastian.
Yeah, well, thanks for asking this question. And in advance, you said we should keep the answers to your questions short. So short answer would be yes, obviously, keeping in mind what we have just been witnessing, I think that we will definitely be prepared in a better way. But if you ask for a more detailed answer, I think this would take quite some time, but just let me share a few insights. So first of all, the main question is, who is we? So are we looking at this question from a perspective of national member states of or as the European Union, or even non-European member state? And I think that the answers would be quite different depending on the perspective that you're coming from. And the other aspect is talking about perspective. Of course, it depends on what are we looking, so what's our background? Do we look at it from a perspective of medicine? Do we look at it at a perspective from public health, from an economic perspective, or from a societal perspective? And I think we've discussed a lot of medical views so far, but probably what we have not yet discussed in detail, and probably is not even in the scope of this conference, are these other views or angles that I just mentioned. So short answer is yes. Long answer would probably lead to another conference or at least another panel.
Thank you, Sebastian. I think we will have a lot of conferences discussing this issue. I would like Adriana perhaps to give a remark on this. You have to unmute. You know, that's the thing we hear mostly in the whole world now. Oh, excuse me, I was muted.
I know, I know.
Perfect, Adriana.
No, actually, I agree totally with what was said, and I don't think I can add very much more. I think that all over this conference, this session, we have heard how difficult it is to put together the data. We have plenty of data. We are accumulating data and we do not know how to read them, how to put them together. So I think this is the key issue, is the issue that we will hear about more and more. I was talking about a Rosetta Stone. We need a novel Rosetta Stone to talk together. And then the other point that is important, we need also the willingness to talk together. And as you saw from the poll that we had, it's not clear that everybody is willing to share data with the other scientists. So we really need a paradigm change in this sense. And well, I hope we will have it soon. And I hope that what is happening to us is obliging us to have it.
Good answer. As I said before, I like the metaphor about Rosetta Stone, and it might be that the language for the future will be machine learning. So, Alfonso, do you have a remark on this?
No, I essentially agree. We are better prepared to some level. We know better. We have some data sources that we didn't have ready a year ago. And there are big movements to make data accessible. So all this is positive and will be a yes answer. We are better prepared. But still, if we really think how the health systems are going to respond to a second wave that is very likely going to happen in the autumn, the truth that we are not going to be better prepared. So the full transformation of the system that is required will take some time, even with the best tools and the best will and with some funding. Transforming the full health system at European level is not a small task.
Good. Adriana, you were muted. Did you have something you would like to add? No, we can't hear you again.
I'm fine. No, it's okay. I'm fine.
Perfect. So, Sonja, what do you say about our preparation for the next pandemic? What will we take with us from this one?
If we're thinking of the next pandemic as not this one, but another one that's going to come in a couple of years, yes, I think we will be better prepared. But as Alfonso just said, this is not going to be in weeks. And we're already a bit better prepared than we were in the spring. But to truly be better prepared will take probably a couple of years. But I think this is really a great accelerator. People realize that we need to work together more closely. And a lot of people are more willing to share, and regardless, of previous ego or, who gets to publish this. And I think this doesn't matter so much anymore when people are dying, and that's good. I mean, not that people are dying is good, but that people don't care.
We got you there.
Just no, a crisis brings people together, and that's a good thing.
Yeah, it bring us together, but it also keeps us isolated. So that's the tricky part of it. Klaus, do you have any thoughts about this?
Yeah.
About the isolation or about...
No, if we are prepared for the next pandemic, what we have learned and what we should think about.
I think we're definitely better prepared. The experiences we made, they resulted from the lockdown, changed the way we anticipate how healthcare delivery is performed. And in Austria, we experienced that something would have taken probably 5 years to develop, teleconsultation or telemonitoring, e-prescription, it was there in 3 months, not even in 2 months. And this is something we will need not only in a pandemic, but it is a much better preparation than we had in March when everything went into lockdown.
Good, perfect. Carolina?
Yes, I cannot agree more with everybody before me. we definitely will not be better prepared for the autumn, but we'll definitely be better prepared for the next pandemic, hopefully not coming anytime soon. But what Klaus just said, we're much better prepared in the sense of learning fast. We're in a very fast learning curve right now. And in terms of technology, we're really learning how to adapt the systems we have already in place for other areas of life to the current situation. So we can transform it very easily to the health system or any other area. And I think it also applies to machine learning and all the models we create for other applications. We start learning how to apply it immediately to something different that we used to use them. So I think we're gonna be better prepared, hopefully.
Thank you. And Ullrich?
Yeah, thank you. So what can I add? Yes, we are better prepared. I think the most important preparation is the awareness that the pandemic has created, that pandemics are real, no? So that it's not something vague or from Hollywood movies, but it's really something that can happen to all of us. So I think this mental awareness, that's a big step towards being better prepared. And we are better prepared because we have now built quite a lot of technology. We have come up with processes that help us to combat COVID. And we will be able to prepare even better because we are aware of still all the problems that we have. No? So data exchange and other things. So we built something, but we know what's still left, the big gap that's still left to be really prepared for whatever is coming next.
Good. Good, very good input from you all. I saw also on the chat that we had a specific question to you, Ullrich. What about the specificity and sensitivity of the Centogene test? False negative or positive results are always an issue. Can you do some short remark about that?
Yeah. So the best answer is actually regarding the positive or negative results and reliability. So I mean, we have been using the test internally in the company. So every person gets tested twice a week. We have 500 employees, and we've been doing this in several months now, and we had 20,000 tests basically. And we had 3 positive tests, and these persons, they were really positives. So they had these symptoms, and we didn't miss anybody, and we had no false positives. So from the numbers that we can survey best and where we know best what they make us really, really confident regarding the reliability of the kind of tests that we have implemented here at Centogene.
Thank you. I was thinking I will wrap up this because I think we are all interested in having lunch. But if you see this image I put up here is for me a way of understanding that the humans and the technology will bring us together. We keep hands for the future. I've been thinking during your presentations here today that we often talk about the importance of data, but I think it's also a very dualistic way of thinking, because most of us say that it's the oil for the future. The data is the oil for the life science sector to grow and expand and to be better. But I'm coming from the healthcare. Sometimes I think that for us, data is the blood of the healthcare system. We need it, and we would need to use it to really get life going. So I will close this session with saying thank you to you all, and I will send back with you, think about who am I? Is it my data or my narrative story? So with that, thank you very much for your attendance.